welcome to this episode of Conversations in Health and Care Improvement. It's lovely to have you with us. My name is Amar. I'm the National Clinical Director for Improvement at NHS England and the Chief Quality Officer at East London NHS Foundation Trust.
And hi everybody, I'm Pedro Delgado, Vice President at the Institute for Healthcare Improvement, and it's a real privilege to be here with you today for another conversation in health and care improvement as we progress with the episodes of this series. Today joined by Jane and Adrian, who Amar will introduce in more detail.
Thanks, Pedro. And Pedro and I are delighted to host this session today focused on the topic of safety science and how the field of safety has evolved over time and where it's heading next. And really privileged to have with us two fantastic guests, Professor Jane O'Hara and Adrian Plunkett. So thank you both so much for joining us today and giving us the benefit of your wisdom in this field. So I just wanted to invite each of you to say a little bit about yourselves and your backgrounds and your interest in the topic of safety. I wonder, Jane, whether you might start us off.
Yeah, thanks. It's a real pleasure to be here. So I'm a sort of lapsed psychologist. That was what I did, or reformed psychologist, maybe we might say. That's the sort of background that I had when I first came into this area. Moved through sort of organisational psychology into health psychology, and then started working with somebody called Rebecca Lawton, who introduced me to this whole world of patient safety. And so since 2010, I've been working exclusively in patient safety and health services research. And it's so lovely to be invited onto this because I do like to consider myself now a sort of wannabe safety scientist. So it's definitely the area I think that I'm most passionate about now is bringing safety science into patient safety.
Fabulous. Thanks so much, Jane. And also joining us is Dr. Adrian Plunkett. Adrian, you're coming from a slightly different perspective now because you're a practicing clinician, aren't you? And you're probably best known for creating learning from excellence, which I think is now such a global movement that's helping us learn from best practice. Adrian, say a little bit about yourselves.
Yes, hi. Adrian Plunkett is my name. I'm an intensive care consultant at the Children's Hospital in Birmingham, so full-time clinician. And I think I've always been interested in how people think and how people behave. Actually, looking back on my life, it's always been an interest of mine. And yes, I started the Learning from Excellence movement approximately 10 years ago after I reflected on experiences I had as a patient. So I realized whilst being a patient on a couple of occasions that there was a lot of things in my episodes in my care that were going really well, and there wasn't really a method to capture that and learn from it other than just writing a letter of gratitude, which I did, and then discovered it was not received by the people for whom it was intended. It's sort of indicating that there's not much status given to these things. So, but that sort of inspired me to think, well, let's try and capture episodes of good practice, and we called it Learning from Excellence, and we mirrored the prevailing approach to learn from things going wrong through adverse incident reporting. So we created excellence reporting, and it's kind of spread as an organic community of practice around the NHS and indeed overseas, which is great to see. And it's definitely aligned with safety, but I think it actually incorporates a bit more than safety, and we can perhaps get into that as we go through this conversation.
Thanks, Adrian, and welcome to you both. We should say when listeners have access to this podcast, it will be date X as it happens today, as we're addressing the topic of safety and learning and improving. It's World Mental Health Day. So we should invite people that are listening, whatever day of the month, year, or week it is, to take care of yourselves and be kind to yourselves first. I'll start with a very broad question. And Jane, we can start with you maybe on your reflections. The field of safety has had some epicentric milestones, perhaps to Earth is Human a number of years ago. I remember James Reason's writings, Liam Donaldson's report. I mean, there's been, depending on the geography that you're in, more or less activity from the year 2000. Before, of course, there's been a forever emphasis on safety. It just seems like it picked up momentum back then. I wonder if you can both start with a quick reflection of how you've seen, we'll start broad and then we'll get more specific, how you've seen the field of patient safety evolve over the last 20 years.
You're right, Pedro, that I think the patient safety movement in earnest began globally in the sort of turn of the century. So, and there were some seminal publications, so To Err is Human in the US, Organisation with Memory in the UK, which really set out, I think, the scale of the problem or the burden of patient safety incidents. And that's really necessary because we have to explore the problem, don't we? We have to understand the scale of the problem in order to do something about it. I think, and I've thought about this a lot over particularly the last 10 years as I've started to work with safety scientists more intensively and learn from them. I think it's fascinating, really, and I think it's really important to understand the social history of the patient safety movement in order to understand why we've got to where we are, why we think the way that we do about safety. Because one of the key things is that if you go back and look at Organisation with Memory, it actually talks about a range of different theoretical perspectives. So it talks about Barry Turner's work, who was working, whose sort of main contribution really was to unpick the Aberfan disaster and the mining disaster that happened in Wales, and introduce the idea of latent failure into our lexicon. It mentions things like that, but the predominant theory that came through them was James Reason's organisational accident model, which of course I think is probably the most successful model of safety probably ever that's been used. I think when I've looked back at it, what's really interesting though is that for the patient safety movement, we're probably jumping ahead a little bit here, but for the patient safety movement, that translation of that theory became so important because it was one of 2 or 3 theories that were mentioned in that document. And it was then sort of translated into or interpreted as being a Swiss cheese model. And everything has proceeded from that. So not that there's anything wrong with that, but it's one lens. And it's a particular interpretation of that lens. And interestingly, in 2006, I think James Reason himself wrote a paper about the dark side of the success of the Swiss cheese model because people had misunderstood how to apply it and what it meant. But of course, that led to a massive focus on incident reporting and the generation of positive reporting cultures, which is important, but it's become, I think, this sort of industry in healthcare, which we can come back to later, but why we're looking maybe with current policy to move away from that. But I think it's a brilliant topic for a podcast in a sense, because I think knowing what has gone before is really, really important to understand the likely success of what is going to happen in the future.
That's a great start, Jane. Adrian, how have you seen it over time, both in your experience, I imagine, as a patient and also, of course, as a clinician for many years?
Yeah, I mean, I think I can give the best reflections from my point of view as a clinician, and I've been a consultant now for 15 years and practicing for a decade before that. And I think looking back, healthcare is definitely safer. So I think there were things that would have happened 15 years ago that we would just not be acceptable now. But with that has come an awful lot more scrutiny, and we've become, quite rightly, quite fixated on trying to prevent things going wrong. I think there's been a huge sort of proliferation and probably over reliance on incident reporting. And there seems to be still, I think, quite a prevailing blame culture. Like we have a sort of natural tendency to look for what the human did wrong, and I think that's still quite prevalent. It's quite inbuilt and intuitive sort of response to things going wrong. So we've got a long way to go to eliminate that. I've also seen, I think related to my first point really, that the goalposts have moved. So healthcare is safer, outcomes are better, but it doesn't necessarily feel safer because we're constantly picking up new definitions of what might be going wrong. And the last thing I think I've noticed is there is emerging and growing interest in different approaches to safety, which is where I have sort of joined this conversation really. But none of that seems to have mainstreamed. And I'm curious as to why that might be the case. The safety 2, resilience engineering, positive deviance, learning from excellence, exnovation, there's a load of these slightly more different and often positively orientated approaches to safety and quality improvement, which are out there, and there's quite a nice emerging evidence base to support their implementation, but they don't seem to have mainstreamed.
That's fascinating, and what a great starting point for this conversation. I'm going to pick something up and then pass the ball over to Amar. We have continued to see that the overall tone of safety tends to be one that highlights the gaps rather than celebrating the successes. And I know that from daily work experience, there are plenty of successes in terms of keeping patients safe throughout the world. Recently, David Bates and a number of others in Massachusetts put out a study that looked retrospectively at over 2,000 records, and they found just over 22% of adverse events still happening. I think the number in people's minds tended to be 10% at some point. And I think it was a reminder for people of the ongoing opportunities for improving this and for closing gaps. Adrian, maybe I can go back to you. Can you say a bit more about some of the things that we are underutilizing, perhaps, in terms of the emerging science of safety? And Jane, can you reflect on the ongoing gap and the opportunities you see in front of us in the here and now to continue to pursue an even safer healthcare delivery environment?
I think all of the positive approaches that I, at least to my kind of best understanding, are based on, or at least include in their approach, this idea that we can learn from work that is working successfully every day. And that can be a complementary approach to learning from failure. So that I think applies to all of those approaches that I mentioned. I'm coming at it specifically from an explicitly positive approach when learning from excellence, the idea that to complement our attempts to learn from failure, we can actually go out and seek evidence for things going well, which are often happening in plain sight because we're so habituated to successful care that we don't notice it. But if you go out and start looking for it, you realize it's actually happening, and then we can be curious about what are the conditions and the behaviors and the resources that were required to allow that success to happen. That's really how learning from excellence works. I think, I mean, I have got some knowledge around the basis of safety 2, resilience engineering, positive deviance, exnovation, the ones that I've mentioned. But they all feature to some degree that curiosity and scrutiny of successful work that is everyday work, that is characterized by success. Now, often in learning from excellence, we capture their sort of outstanding success as well. But interestingly, when you ask people to report things that are excellent going on around them, they tend to focus on everyday success, which actually has become an area of interest for me to understand what it is that people think excellent care is characterized by. It turns out to be quite everyday success, often characterized by non-technical skills which support the team to deliver successful care. When we look at things that go wrong, we often think, well, how can we how can we come up with solutions to prevent that happening again? And that's a really important and good question. But what we tend to do is try and use our imagination, which is often kind of tainted by the fact that we've just been looking at things going wrong. So it's a little bit hard to come up with solutions to things that go wrong if we're only focusing with this kind of unilateral gaze on, things that have not gone well. But what we can do is, if we get into the habit of studying everyday success, we can actually say, well, it went wrong on that occasion. Let's look at when it goes right and try and understand what were those conditions. Then that can form or inform our recommendations for how to prevent that happening again in the future.
Thanks, Adrian. Jane, what would you reflect on the question or on some of Adrian's reflections?
Yeah, so I mean, I think one of the key, not battleground areas, but one of the key misunderstandings, I think, about some of the more, I would say, well, they're called emergent safety science approaches, but actually they're not. They're older safety science approaches. It's just as I've already described, we set up patient safety around a particular approach, which was slightly different. So I think one of the great misunderstandings has been that we look for what goes well, and as Adrian has talked about, that actually people don't really consider it to be going well, because the reality of delivering care means that you are always making compromises, you are always adapting, you feel like you're barely getting by, you go home and you worry about what you've missed and things that are a problem. It's really difficult to always organise your thoughts around, stuff is going well. And I was reflecting on what you were saying, Adrian, actually, because I remember an early positive deviance piece of work that we did where we identified services that had really good records on readmissions. And we thought, okay, we're going to go on and we're going to speak to them about why they've got such great records on readmissions to learn. So classic sort of positive deviance approach. And we'd start with, you're doing really well, aren't you? And they'd be like, are we? Doesn't feel like that. And actually what we sort of worked out from that was that doing well is just a sort of constant, can be a constant battle. And people find it really hard to articulate what it is that they are doing well, because it doesn't feel like that. If you look back at the sort of resilience engineering type approaches and lots of the wider socio-technical systems type approaches, the assumption is actually what we need to do, as Adrian is describing, is actually look at how care is delivered. So what happens every day? And actually, I've always thought it's quite difficult to sort of say, oh, we look at what goes wrong, we look at what goes well. Because actually, they're just ends of the bell curve, essentially. What we really need to understand is how 90% of the work is happening every day without one of those two, complaints or compliments kind of approaches, really. I think, Adrian, as you said earlier, we need the compliments, but potentially for different reasons, and we should be inquiring about care, essentially. And I think that traditionally we just haven't really done that. And every time, I'm doing some work at the moment on maternity escalation, and we sat with a really great team, work together all the time, and they just don't know how collectively care is achieved. And so I look at that as a researcher and as a person, just like it's a minor miracle how this happens all the time so well. And it's a real testament, I think, to people's adaptability, that things do go well, really well, all the time. So I think that the fundamental thing that probably needs to change, and that we are starting to see a little bit more of, is how is care delivered? What is the shared understanding of that? And from that basis, we can start to improve care. I think for so long, we've assumed that deviations from protocols which are set by people often so far away from the coalface and don't understand how care is achieved, we see deviations from that as failure. And actually what we need to be understanding and starting from is how healthcare improvement can work up from how is care actually achieved, how do we support people to do the work that they need to do in order to create safe care and to get home without all the mental health problems, the burnout and whatever it is that they might be achieving around a difficult system.
That's really clearly articulated. Thanks, Adrian and Jane. It makes me think about a couple of questions, both really framed about how we learn. Over the last few decades, there's been a lot of focus around learning from other industries about safety, particularly civil aviation, the nuclear industry, submarines, and others. And I'd be curious on your thoughts about how much similarity or difference you think there is between healthcare and those other industries, such that how much can we learn versus how much really needs to be different, given the different complexity and the human-centered nature of healthcare, which I think is different to some of those other industries. And the other thing I'd be really curious to hear about is whether you feel improvement as a field, quality improvement as a field, is sufficient to really be curious and learn about how work is done and think about better design of the system, or whether you think there are things that are currently missing in that approach which we need to build in to really adopt this way of thinking about safety that you both described. I know there's two slightly different questions, but both focused around how we learn. Are there things from other industries that are transferable we should be learning, and is our approach to learning that quality improvement has engendered within health systems sufficient for us to do this work? Adrian, do you want to give some thoughts on that first?
Yeah, great questions. Particularly that first one comes up quite a lot in circles in which I move. I think, yeah, clearly we can learn from other industries, and the further we sort of cast our net, the more we can learn, not just from safety critical industries. Actually, I'm increasingly interested in learning from sports psychology and coaching, because it's all about teamwork and getting the best out of your team. I think one thing we could definitely learn from those really ultra safety critical industries is that safety can be taken seriously, safety in its traditional sense. And in fact, we can show that it's possible to reduce harm or adverse events to really, really low rates. But I think we also have to be realistic and look at what's the difference, what are the obvious differences between our industries. I don't know a huge amount about nuclear industry and other safety critical industries, but I do know that if you compare healthcare with aviation, for example, we sit with a lot more risk in healthcare. So we can't just ground the flights or cancel them. We find ourselves having to respond to a massive demand. So we're, from a starting point, taking a great deal more risk. But I think it's difficult to translate much of the learning, but that primary principle that safety can be taken really seriously as a kind of North Star, which is exemplified by those other industries. I think we can use that and where possible try and get some learning. For me, most of the learning, I mean, you asked the question, how do we learn? I wasn't sure if you want us to answer that, but I'm going to anyway. I think we learn I think learning is a change in response to feedback, and the change is either in your knowledge or your behavior or something about the way you go about your business. And the feedback is there all the time if you look for it. So we get negative feedback when we fail. We get positive feedback if we're lucky enough to have that embedded in our systems. And actually, we can go out and just be curious about, gather feedback from the universe all the time about how we're interacting with it. So we're constantly learning. And just before Jane comes in, I'll just say, you asked about QI as well. And I think this is an area where the more positive approach, using positive feedback, understanding success and inquiring into success, is underutilized. And we've got, within our Learning from Excellence community, we've got a growing sort of area of practice where we're using this as a QI intervention. And we've published some work on this, and in fact there is growing uptake on using positive feedback and recognition of success specifically as an intervention. We call it LFEQI, but you can call it whatever you want. And it seems to work. We've only tested it in a few centres, but it's an area of great interest of mine, and I'm hoping that we can conduct some multi-centre research in that, because it seems to be incredibly powerful intervention.
Thanks, Adrian. Any thoughts, Jane?
I've got lots of thoughts on these questions, Amar. These are great questions. So I think there's, I think going back to this whole idea of the last sort of 2.5 decades, we had an initial sort of push within patient safety to do a certain thing. There was what quickly followed was then some sort of not negativity, but some sense that actually that hadn't realised the gains in patient safety that we hoped for. And so naturally we started to look for, other places. And of course, aviation is the classic one with some crew resource management type approaches and different things. But I think your question really is the key question, I think, about learning from other industries, because we don't really know. And in fact, I've got a PhD student at the moment where one of her studies, we're asking that question, like what bits of what industries are actually in any way similar to healthcare, like which industries or what parts of industry should we be looking for? Because of course, when we talk about aviation is an enormously different thing. So you've got flying the planes, you've got all of the ground crew that sit in the airport. These are all different employers, different industries. You've got people running the airport. But, as a user of that system, we don't really see that. But so there is more complexity, I think, than we think about. But we just get these little snippets of, well, crew resource management has worked really well, we just need to apply that. It's worked really well in surgery. And I think certainly some early stuff by Ken Catchpole and things like that, that was focused on those small, teams that come together, and of course things like checklists have been brought in from other industries and things like that. Charles Vincent's done some really nice thinking around this, about actually how we start thinking about healthcare not as one industry, but actually as lots of little industries in a sense. So he describes 3 contrasting areas. So those are ultra adaptive, they embrace risk, so ED and acute medicine might be those sorts of areas. High reliability areas, so things like general surgery, post surgery wards, things like that, which can control some things, but also other things are emergent. And then you've really got the ultra safe environment, so things like nuclear medicine, ICU, where you can reduce risk right down. And what's been so brilliant about his way of thinking about that is actually the things that are going to work in the ultra safe environments aren't necessarily going to work for ED. So it was actually starting to think more, I think in a more nuanced way about this stuff, that actually we can't necessarily apply the same sort of improvement measures across all of healthcare, that actually we need to start thinking about what is the level of standardization that's appropriate, what are the ways that these different areas manage risk. And if I might just then come to your second question very briefly, I did this presentation about, I think it was just before the pandemic, actually. It was with Patrick Waterson. It was a clinical human factors group and Q community event. And he asked me, would I come and present on some work that I'd been doing, where we'd used a really geeky approach called the functional resonance analysis method, which, Adrian, I'm sure you're at least familiar with, even if you haven't done it. It's an approach that comes from resilience engineering. But anyway, we'd applied this to transitional care. So we looked at how everyday work was achieved from coming into hospital through to 30 days post-discharge. So an enormous endeavour. But one of the main things that we learned, that I then presented to this group of people from the Q community, was that actually where you look and the scope of where you look will impact on how you think you might intervene. And this has relevance for QI, because I think a lot of QI traditionally has been quite small, very focused. And my main point was, actually sometimes you might want to do nothing, because actually doing something might muck up the system in all kinds of ways that either you don't know or that you certainly haven't modelled to understand how it's going to work. And there was a little bit of pushback in the room, because it was like, well, how am I supposed to go away? How am I supposed to motivate my teams? And I was like, well, there are things that you can do. And I think, Adrian, you're showing that there are things that you can do. But I think QI as a movement does need to recognise complexity, does need to understand sometimes that we need to be inquiring not just about the thing that you're doing, but the entry points and the exit points and the wider system within which it works. Because otherwise you actually could be introducing all kinds of negative unintended consequences into the system. And I know that my colleague Rebecca Lawson has done an editorial about that not that long ago, and that there are certain sort of rumblings about the need for QI to look inwards at some of this stuff. But I think it's a really important point, coming back to the industry thing, that actually if we can even just start to think, what kind of setting are we in before we do some of the QI stuff, that would be a good start.
I'm very tempted, and I am going to just go for this question. And there are probably 4 layers and 2 sides of the same coin. So the 4 layers are the individual, the team, the department, and the organization. And there's a 5th one, of course, which is national, the likes of CQC and NHS England. And the 2 sides of the coin are the kind of do's and don'ts. So as you're doing your work, as you're interacting with teams daily, with organizations daily, and so on, what 1 or 2 things would you advise them to do and not to do? I'm not asking for magic, quick fixes. I'm not asking for absolutes. I'm just asking you for 1 or 2 things that you may tell an individual who's providing care, a team that's providing care, a department that's keen to do safe care, an organization that's keen to be even safer. And if you want to reflect on what you would tell the likes of NHS England and CQC to do and not to do, just 1 or 2 things that come to mind, if you wouldn't mind just reflecting on that. And again, for the listeners, this isn't about this is the answer to everything, but rather quick advice from 2 people that are heavily invested in learning all the time about how to make systems safer. Jane, maybe we'll start with you.
Oh, goodness, I was hoping to get a little space to think then. Luckily, I thought that this might come up. So well, there's lots of things, but I think broadly across all of those levels is be inquiring. And Adrian, you've already talked about this, and it's a bit of a platitude, isn't it? But it has a long history in safety science, and I remember reading about how James Reason once said that the price of safety is chronic unease. And I think if you reflect on the difference between that type of approach and our assurance models in I am assured, we are safe, it's fine, rather than a process of, okay, how safe are we today? How do we know that we are safe today? And how do we continue with that inquiry? So just be inquiring, and I'm sure Adrian would agree that inquiry has to be about what is going on rather than just what the problems are. And how are we managing today? How are we managing to get people through in ways that actually are safe and that we can all go home happy? So I think, and I think if you unpick that, there's a few things for the multiple layers. And actually, interestingly, this was something that I said when I came down to ELFT Amar and presented recently. Was I think we hope for these sort of holy grail safe one measures, and it's never going to be like that. No measure is going to be perfect. Every measurement has error, And actually, lots of measurement is much more subjective than you think it is. And there's a whole host of work from social science which will say even the most quote unquote objective measures will have elements of subjectivity. So if you proceed with that in mind, recognizing that actually being uneasy about safety is actually the positive place to be in, because that's going to drive inquiry. And then the final thing that I'd say, and this applies to all levels, is to really seek multiple perspectives. So, if you're in a team, try to, and I know this is sometimes almost impossible, and we don't have the infrastructure to do this, but try to speak to your colleagues about how things are going. Get multiple perspectives on that from all places, not just your clinical colleagues, all the people that support the work of the setting in which you are. And of course, I would say this, after doing patient and family engagement and involvement for 14 years, I would say speak to families, because they are, and patients, they are a unique and largely untouched resource to understand how safe care and the quality of that care is. So yes, I would say don't rely on one measure, be inquiring, and seek multiple perspectives.
Adrian, you've had a bit more time to to think about it.
Well, it's hard to add to that because I agree with all of that. I think if I had to encourage colleagues and teams to do one thing, I'd say, unsurprisingly, spend some time looking for what's working and be really sincere about it. Try and inquire into it. Don't just sort of casually say you're doing it, but actually spend some time specifically looking for it. And interestingly, I think it's much easier to identify success and things going well when you actually dedicate the time to it. Don't try and do it within another meeting at the end of a checklist or during a investigation. It's actually requires a dedicated mindset. And then there's a few things not to do. I think Jane's covered it really, but I would say let's stop blaming each other when things go wrong. And perhaps also try and avoid these kind of knee-jerk responses to when things have gone wrong, because it's difficult because we don't have time or resources to actually really figure out how to make the systems better. But if we can avoid coming up with oversimplistic solutions to problems, that would be good. Everything is interdependent. We've said, I think that's words already been used today in this conversation. And as I get older, I see that more and more clearly, more comfortable seeing the place we work. In fact, the whole world really is just one sort of unity, or it's not even a unity, it's like a non-duality, to use a spiritual term. Everything is interconnected. There's no real separation between things. But when we try and respond to things going wrong or design QI projects, we break everything down into discrete little pots. If we can retain some kind of knowledge that one thing depends on another thing and everything sort of has a knock-on effect, then I think that will help us making wiser decisions about responding to things going wrong, designing our services. I like this idea of design. When we design our services, we should do it with the patient in mind. That's the point of what we're doing. But when we deliver our service, we have to hold the patient up there, but we should actually probably deliver our service with the staff in mind, because they're the people who are doing the work. If you don't look after the staff, if we're blaming them all the time, scrutinizing, under-resourcing, then we're not going to be able to deliver the very vision of what we're trying to do, which is to deliver patient care. So design with the patient in mind and deliver it with the staff in mind.
Wonderful. Have an inquiring mind, appreciate the interconnectedness of everything, and design with the patient in mind and the staff in mind too, who will have to deliver on a day-to-day basis. That's fantastic advice. As we get to the end of this conversation, I wondered whether we might invite you both to cast your minds into the future, and if you were to look into your crystal ball and imagine or predict where you think the future of this field might be 5 or 10 years from now. I mean, you both described really trying to address, this continuum of learning where we've probably been overly focused on what goes wrong and really thinking about how we learn from what goes well, but also how work is done every day in that middle of the distribution. I'm I have an anxiety about safety science being seen as almost separate or very specialist and different to the way we think about leading and the way we're approaching quality more broadly. And there's so much intersectionality between the different domains of quality that we have to pay attention to. But I wondered what you thought about where we might be 10 years from now. How far do we think we can get in really embedding this way of thinking and living and seeing the world around us in the world of the busy, complex world of healthcare? Jane, any thoughts about where you think we might be 10 years from now?
Well, I think there's been some real enabling factors recently. So, the publication of and the implementation of the patient safety incident response framework has, it's probably the first safety policy which really is expressing any sort of safety science explicitly in that policy, and the move to, and I know it's not without its detractors, but the move to support organisations to be proactive as well as reactive in responding to incidents and understanding how safe they are, I think is a real positive move in that sense. How well that will do will be, how well that will be implemented or received or enacted is another thing entirely, I think. But and depends on multiple factors, and we know where we are with the health services it is. So, but the intent is there, I think, and I think policy will always be a central lever to enable people to do the right thing or not, and all of that sort of stuff. I think looking ahead, it would be great if we could start to think, you said it earlier, Adrian, and I really liked it. We need to consider ourselves as a safety critical industry. I think if we could take safety seriously, which I think we are starting to do, we've got patient safety specialists, the role there, I don't think it goes anywhere near far enough, personally, but I would say that. I think that we are starting to do that, but I think if we could see ourselves more as a safety critical industry and put good, really focus on what it is in healthcare to apply known approaches to safety science, I think that would be a good way forward. I think one of the things that is capturing the attention of lots of people at the moment is the idea of safety management systems. I know, and quality management systems. I know this is something, Amar, that's very close to your heart and you've been working on a lot. And at policy level, certainly that's getting a lot more focus, and I'm delighted to be able to, contribute some of that at a national level to think about how we might apply those sorts of approaches. So I think, it's about saying we're a safety critical industry. How do we get that in our infrastructure? How do we create those roles and make them work? And then from that, we might start to be able to, in a recursive way, actually start to get people to take safety seriously. I think, Adrian, I'm always in awe of people that go out and deliver care safely every day. It's an incredible achievement to do that, given, as you say, it's so complex. It's incredibly complex. But how we can do that more systematically, I think, and support people to do that is really, I think, the future of that. And the last thing I would say then is, and again, this is an area of my work and my current focus, is how do all of these different agencies and outside bodies, influence the work of people on the coalface? Like, what are the things that the CQC could do to be more responsive, for example? How does policy influence and help support people working safely or not within organisations? So much less a focus on just what frontline people do, and actually more that multi-level understanding of how to create safety, I think, would actually perversely support people to do the work more safely. So that's what I hope really for the future of patient safety science, shall we call it, for the next 10 years.
Brilliant. Thanks, Jane. Adrian, your thoughts for the future?
Well, I think 10 years is not very long. We've been doing learning from experts for 10 years, and I think I have seen some changes in terms of recognition and people accepting that view as valid. But as I said at the start, there hasn't been a great deal of mainstreaming of this approach. I would think I'd like to see a sort of greater, I'm not sure how we'd measure this, but a greater understanding of what we mean by safety, and perhaps a sort of evolved definition of that, not just be focused on harm, for example, but to incorporate, like Holnagel's safety is a condition where as many things as possible go right. So this kind of slightly harder to describe concept. That would be nice if that over the next 10 years, these ideas permeate through into the leadership and onto the shop floor, into the patients and families, that actually what we mean by safety is slightly different. I don't think that will happen though. Like I'm a little bit skeptical about how much change can happen in 10 years. That doesn't mean that I won't keep banging the drum and trying to influence where one can. But I've noticed over the years when one meets with people in significant leadership positions, there's such a prevailing preoccupation with harm alone. Of course that's important, but it's so hard to get out of that, and it appears that one appointment after the other seems to be impacted by that same very strongly held view that that's the only thing we should be working on. We can only look at positive approaches once the harm has been removed and reduced to zero. But I'm pretty clear that will never happen. But we could actually make things better by broadening our whole definition and our approach. We know now that we have known for years, but it's becoming more prevalent, this knowledge that the way we behave in a non-technical way impacts the way we perform. So if we behave pro-socially, we're likely to perform better. That will lead to a safer environment, better outcomes for patients. Perhaps that's something that is achievable in the next 10 years, is to get a much better understanding throughout the whole of healthcare that the way we behave impacts our performance.
What a great rallying cry to end. Pedro, I'll leave you the unenviable task of trying to summarize and bring together our learning from this conversation.
Yeah, look, the learning is a forever effort, and that's probably what I appreciate the most from Jane and Adrian today. It's that the invitation is just an open door to be curious, to talk to each other, to be civil, to behave in ways that are conducive to better safety, to be both chronically on a kind of chronic unease mood, and seeing ourselves as a safety critical industry, but also learning from excellence, and those balances are never easy. So never a promise that's simplistic, always an open door to continue to learn together, and I think we could just celebrate that, and I hope that the people who are listening will leave this conversation with a sense of possibility and optimism despite the complexity of the task. It won't get easier. What will be always open is the option of learning and trying to improve what we do in service of safe as possible. So thank you, Jane. Thank you, Adrian, for a wonderful conversation, and Amar. I know we've got much more coming in the coming conversations, but anything from your side to end?
It's been an absolute joy. Thank you so much, Jane and Adrian. Full of wisdom and learning over this conversation. I've learned a lot, and I hope our listeners will find something that they can take away and try in their own day-to-day practice and behaviours too. So thank you so much, Jane and Adrian. And from Pedro and myself, thanks for joining us on this episode, and hope to see you on the next one soon. Thank you, everyone.